Welcome to the Physician Associate Podcast.
Hello and welcome to this episode of the Physician Associate Podcast. My name is James. Today, I'm delighted to be joined by Dr. Sanjiv Ahluwalia, who is a GP and head of the medical school at Anglia Ruskin University. Welcome to the show, Sanjiv.
Thank you very much. I am currently the head of School of Medicine at Anglia Ruskin University, and I'm also a practicing general practitioner in the NHS.
Thank you so much for coming on to the show today. I've been wanting to make an episode about this new idea of an apprenticeship route into medical training and into becoming a doctor as an apprentice. Could you set the scene for us by explaining a little bit about the workforce pressures and the problems with medical education pipeline and the sort of shortage of doctors, perhaps, to start with?
So as our population grows ever older and as we are living longer with more complex diseases and our ability to treat conditions that we wouldn't have been able to treat 20 or 30 years ago, we are seeing an explosion of demand for healthcare in the NHS and in the UK, which means that we've got to maintain the levels of the workforce that we require to meet those needs. We have a demand and a pressure for more doctors in the NHS. We already know that we are below the OECD average internationally. We are trying to increase supply through our traditional routes, but that is not likely to be enough to meet our demands in the next 5, 10, 15, and 20 years. So in 2017, the Department of Health, Jeremy Hunt was the health minister at the time, commissioned 5 new medical schools, one of which was Anglia Ruskin University, to produce 1,500 additional doctors as a reflection of the fact that actually we had a demand and a need for more medical workforce. At the same time, we've had Brexit that has come, which means that actually traditional supply routes from Europe have dried up. And equally, our reliance on international medical graduates remains very high at the present time, but we can anticipate in future years that countries abroad will wish to keep their medical workforce within their own countries. So we are needing to make sure that we as a country are independent in our supply of medical workforce, as we should be with other workforce groups as well.
How does it work? How does the government know how many medical schools it should have? How does it pay for those medical schools to be set up? Who's doing the sort of number crunching in terms of workforce planning?
So the workforce planning remit sits with Health Education England, which on the 1st of April this year moved into NHS England. And they use an extensive array of information, including patient demand, statistics about health service care and usage, projections about populations and existing demand for workforce, including vacancy rates, to come up with the numbers that are required both in the here and now, but in the future as well. It has to be said that workforce planning is more of an art than it is a science, and it tends to do well in the short term, but in the medium to long term, predictions can be very variable. So when you cannot predict that something like Brexit is going to happen, then sort of long-term analyses of workforce trends are subject to inaccuracy. So one has to be very careful when interpreting long-term workforce trends. The other thing is the relationship between workforce, education training, service, and finances. There's no point having workforce projections that are basically unaffordable as a nation. So one has to test workforce projections with financial reality and service delivery. So part of the reason why Health Education England, one of the potential big advantages of moving Health Education England into the NHS is to ensure that the planning of the services that the population needs are aligned to the money that is available, which then makes sure that the workforce projections that are made are much, much more realistic. And the anticipation is that by the three pieces of the jigsaw coming together, we will start to see much, much greater reassurance about the projections around the workforce. I hope that helps answer some of those questions. In relation to the medical schools, medical school numbers, so undergraduate numbers for doctors, are managed through the Department of Health in close association with Health Education England. So the Department of Health puts in place a tariff to supply resources for medical student numbers, and universities respond to requests for any expansion that comes up. The last expansion, which was in 2017, was a competitive process where universities had to put in a bid to demonstrate that they were capable of delivering the additional numbers that are required.
And is the same true for physician associate courses? Is somebody planning how many PAs might be needed in the workforce and where they should train? And
yes, indeed, there is a similar approach taken to physician associates as well. So what tends to happen is that employers will define what numbers they think they can accommodate and need in their clinical services. These are aggregated often by the regional teams of Health Education England, and that intelligence is then used to commission physician associate programs from universities. There will be conversations had with employers. There will also be conversations had with universities about how realistic delivering those numbers is. One has to remember that these programs, both medicine and physician associates, are dependent upon issues such as space to teach, both in the universities, but also in the hospitals and GP surgeries. So clinical capacity is always something that we have to keep very closely in mind when we start to commission physician associate programs, or for that matter, any other educational program that the government or the NHS wishes to invest in.
From a physician associate point of view, I think at last count there was something like 35 PA courses now across the UK, predominantly most of them in England, churning out in the region of about 1,000 PA graduates a year across all of those courses, I think now. In the grand scheme of things, that's sort of a drop in the ocean, isn't it, compared to the number of medical school places that are churning out doctors every year?
Yes, it is actually. So we are waiting for an NHS workforce plan that gives us some indication about whether or not there will be an expansion of undergraduate medical placements.
The traditional route of becoming a doctor has always been going to university, funding yourself through your undergraduate or postgraduate medical education, 4 or 5, maybe 6 years of university, and then coming out as a doctor with your award from the university. Increasingly, there is a move for apprenticeships coming into the healthcare workforce. There is a PA apprenticeship, and I've done a podcast episode about that. But I'm also intrigued as to the plans that are coming forward for a doctor's apprenticeship. Could you explain a little bit more about that for us?
The idea for a medical doctor apprenticeship started in 2017. The medical director of Health Education England, Professor Elizabeth Hughes, initiated some discussions about developing a medical doctor apprenticeship. That piece of work, which has taken about 5 years to progress, resulted in the publication of a medical doctor apprenticeship standard by the Department of Education in July 2022. Since July 2022, Health Education England has asked for expressions of interest from universities to see which schools of medicine would like to pilot and develop a medical doctor apprenticeship route. And to the best of my knowledge, there are 3 universities in the UK that are currently looking to pilot this, including ourselves at Anglia Ruskin University, the University of Lancaster, UCLan, and the University of Plymouth in the southwest of the country. So the 3 universities are currently in discussion with each other. We are taking slightly different approaches to developing the undergraduate apprenticeship route. And we are in the process of crafting what this might look like, as well as understanding when these pilots might start. The apprenticeship route, I think, has a number of features to it which are distinct to the traditional direct entry route. The first is that an apprentice will also be an employee of an NHS provider, whether that be a hospital or a GP surgery, which means that they are earning and learning at the same time. The second feature, I think, of an apprenticeship route is that it allows people who otherwise would struggle to get into medicine for financial or other reasons to be able to access a route into the medical profession. The third is that it is part of a wider agenda of making medicine much more accessible to a wider population as well. So for me, those are sort of 3 very good reasons for wanting to develop a medical doctor apprenticeship. Now, some things that it isn't, because I think it's important to debunk some myths as well. It isn't a second-class degree. So all apprentices will have to undertake the same assessments as the direct entry route. They will get the same degree as the direct entry route, and they will be registered with the GMC in the same way as any traditional medical student. They will also have to ensure that they meet the graduate outcomes that are expected of the GMC. The doctor apprenticeship route isn't an easier route. In fact, I suspect it will turn out to be a more challenging route. And I think it will require people capable of being able to earn and learn at the same time and achieving the standards and expectations of both their employer and the university at the same time as well. It will require a significant degree of flexibility, capability, intellect, and I think hard work. I hope that helps describe both the differences and the similarities.
That's brilliant. Thank you, Sanjiv. To my mind, I'm wondering about perhaps physician associates or other related healthcare professionals who may want to go on to become a doctor. This could be perhaps a route for them into the medical workforce?
Indeed, it could be. It could very well be a route in for people who have already got some life experience and some work experience and have made a decision that actually trying to go back through the direct entry is neither affordable from their life perspective, nor indeed viable or worth it. But this may allow people to continue to be able to work, support their families, and to consider a career in medicine. It is also possible that we could target an apprenticeship program to some areas of the country where traditionally it is difficult for young people to get into medicine because of economic or other reasons. And I think that's another opportunity that exists with this. So the apprenticeship route, I think, offers greater flexibility. The other unique and defining feature of the apprenticeship route is the relationship between universities and employers, because there is a much greater emphasis on the role of the employer in supporting and nurturing the apprentice, whilst also working very closely with the university to ensure that the university is catering to the educational needs of the apprentice, and the influence that the employer has on the university's provision, which I think is a healthy, positive way of forming close working relationships and making sure that the apprentice is successful in their endeavors.
It sounds like a win-win all round to me. Are there potential negatives, or can you foresee criticism of the scheme?
Yes, I think there are some issues with the potential issues with the medical doctor apprentice. Medicine itself is a pretty hard course, so there are questions about how do you integrate working whilst learning at the same time. Does that mean that the course is going to have to expand beyond the traditional 5 years and be longer? Does it mean that actually the apprentices are at risk of burnout and overwork? So there are some concerns that we have to think about and address at an early stage. We have to decide, how are we going to recruit these individuals? What is the nature of the recruitment? What do we require as a sort of minimum entry requirement? We just do not at this stage have a strong view on that. So we're going to have to do some work, but we don't want to put people up for failure. So we want to make sure that they have the minimum amount of academic capability required to undertake the medical degree course. But at the same time, what we don't want to do is to put the bar so high that actually the people that this is designed to try and bring into medicine are unable to achieve that high bar. So we've got a very tricky balance to achieve there as well. We need to make sure that the experience of these apprentices is a seamless one when they transition from university to work and from work back into learning again, that it isn't a burdensome experience, and that actually they see that there isn't tensions that emerge between organizations because the organizations are not talking well to each other. So there is a good need to make sure that we've got really well developed relationships between the employers and the universities to support these apprentices through their journey. There are some cultural issues that we need to attend to. A belief that somehow anyone entering through the apprenticeship route is a second rate, or perhaps not as good a potential doctor as someone who has come through the traditional direct entry route. So we're going to need to make sure that we give good consideration to how we disavow some of those views and beliefs and empower our apprentices to speak up and be supported in tackling any potential bias that they may experience. And then I think finally there is a need to think about how we support those apprentices through to being able to live and work in the same space. So, there's no point an apprentice coming all the way from Edinburgh to ARU if actually their roots are in Edinburgh. And so there's something about how do we ensure that we keep people who go through this process, build up the workforce in a local area, and people to have a connection to the place in which they live. So there's quite a significant number of challenges that we have to overcome in making this a success, and we have to be open-eyed to the challenges that some of our apprentices will face.
Brilliant. Thank you, Sanjiv. I'm sure this has been of interest to lots of physician associates, maybe PA students who've been listening to this episode. They may want to find out a little bit more about the apprenticeship options. Where would you point them to go to find out more information?
Well, thank you, James. Yes, I think we are at an early stage of the development of our program, and I would recommend that actually at the start of the next calendar year, we will have much more information available because we're currently doing the design work as we speak. So I would point people to the website of Health Education England, where I know that there is a lot of information already about the Medical Doctor Apprentice. Over time, we will be adding content to our websites, as will other colleague universities as well. So I would suggest that actually people at the moment turn to the Health Education England website for further information.
And I'm just wondering, so as well as the potential students who want to become doctors, what about the employers who may want to work with the university to find out more about the apprenticeship scheme as well?
Certainly at Anglia Ruskin University, the university is doing a lot of work with our local provider partners and HEE regionally to get this off the ground. So we've already been reaching out to our employer organisations and had very high level conversations at board level with colleagues who have unanimously been supportive of developing this program. I have been absolutely bowled over by the support from the NHS to want to make this a reality. So we are going through that process. And in addition, the General Medical Council, who is the regulator of all medical education, is also going to need to look at the content of the program and make sure that it is content that we are we're achieving the standards that it expects of medical schools. In addition to all of that, there is also a regulator for apprentices as well, and we have to meet their standards too. So I think the simple way to put it is that actually there's a lot of design work going on to ensure that any medical degree apprenticeship that gets off the ground in the UK has got the right design, the features, and is all based around making the apprentice's experience a successful one.
Brilliant. Thank you. I'm sure there's loads of work to do to get it off the ground, but it does sound really exciting. Thank you so much for joining me on the show today.
Thank you very much, James. It's been a pleasure.
And thanks to you for listening as well. I hope you found that interesting to find out a bit more about the doctor's apprenticeship route. Don't forget there's also a physician associate apprenticeship route, and there's an existing podcast episode on the feed about that. If you've got any ideas for future episodes of the Physician Associate podcast, I'd love to hear from you. Please reach out to me on social media at PA Podcast UK. And I hope you'll join me again for the next episode.
Thanks for listening to the Physician Associate Podcast.